Much for the announcements, but I'm going to start to talk about our distinguished guests. And those of you who don't know her, Dr. Chandra Ivey, she is a laryngologist. She's currently practicing in New York City, the New York City. She's a partner in the ENT and Allergy Associates, and she is in the city, on the island. And she did her training. Her fellowship in laryngology was Dr. Peek Woo, who's also in New York City. She did her residency at the University of Cincinnati. That's where I met her almost 20 years ago. Oh my goodness, time sure does fly. And she got her medical degree from Cornell, and she did her undergraduate training at Harvard. Sorry, training. She got her undergraduate degree at Harvard University. And it is such a pleasure to have you here today. And she's going to help us celebrate women in Odo, as well as talk about the aging voice. So I'm going to let you take it away. Thank you again, Dr. Ivey.
Thanks, Romaine. I'm going to try to do this for about maybe 35 minutes, so we have some extra time. It's really a pleasure. I feel so grateful to be able to speak today, not only because this is a wonderful society, but because it is Women in Otolaryngology Day. My topic, as I said, I'm a laryngologist, so go figure. I'm going to talk about the aging voice. And I wanted to first start by just saying these words: old, aged, senior, elder. You know, Merriam-Webster really defines this really basically as just having lived a long time, no longer young or belonging to the past. But unfortunately, in our society, it's really the connotation that we hear, which is deterioration, frailty, obsolescence, senility, and unfortunately, irrelevance. So this is why the voice and aging with the voice becomes such a hot topic for laryngology. It's part of our perceived identity, just like facial features, hairstyle, clothing, body posture, and gesticulation. And what I want to try to answer a little bit is, why do we sound old? I have a few voice samples here, and I'm just going to have, this is people counting, okay? So out loud, count to 10.
Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great. And we'll go to the next. Out loud, just count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great. There's a third. Just count to 10 for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great. And last one. Out loud, count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great. So each one of these people has a voice issue, but I would bet money that all of us could tell the difference between the younger and older male and female voices just by our perception. Now, we have a much aging workforce. We are seeing people who are working not only into their 60s, but into their 70s and sometimes 80s now. And we even have a new term of old, which is typically talking about people over age 85. And these people are active in society. They're not just sitting around retired, and we get to see them in our office complaining of these problems.
So out loud, count loud.
Out loud. Okay, let's try to move on. So presbyphonia literally means aged voice. What I'd like to talk about today is normal vocal fold development over time and with age, voice complaints that are related to age, of what tools we have for vocal assessment for presbyphonia, as well as non-surgical and surgical treatments. And then if we do have time, there's some really kind of cool emerging technology that I really hope is going to be on our forefront of things we're going to be able to offer patients. So I want to start with normal vocal fold development, and there's a couple different stages of this. There's the look at the neonatal and infant vocal fold, and then going into adolescence, and then what happens histologically, as well as with other things besides histology, as people get into the more elderly age group. And most of this, you need to really know the basis is with the 1974 body cover theory. So the idea is that you have this body, which is really the thyroarytenoid muscle, and then the cover, which is the epithelium, with this lamina propria between that allows for the normal vibratory function of the vocal fold. So just this had been hypothesized and sort of proven over time, but what we know is that neonatal vocal folds don't actually look like this. Now, obviously, we don't have a ton of information on neonatal vocal folds there, and the theories are not necessarily well substantiated. Depending on the papers you read, you can have some contradicting ideas, but really it's commonly accepted that the tri-layered vocal fold that you see in adulthood probably is underdeveloped, if not absent, in the neonate. And then this photograph here shows the anterior and the posterior macula flava. And research has shown that they play major roles in extracellular matrix development over time. And the other thing that does seem to be pretty evident is that you need to have vibration or phonation over time to stimulate the production and the metabolism within this extracellular matrix in order to form that layered structure. So this diagram shows on the left a normal tri-layer vocal fold, and then the three on the right are considered neonatal, infant, and child vocal fold, where you're starting to get development of a somewhat layered vocal fold over time because of the progenitor cells and the matrices that are being laid down from these the anterior and posterior macula flava. Now, adolescence is a pretty important time for many different reasons, but in vocal fold development, it is known that the vocal fold tissue is estrogen, progesterone, and androgen sensitive. It is thought that the differences during adolescence between male and female development is really more due to the circulating hormone levels, not necessarily the receptor differences in the tissues. And over time, Jean Abibol, as well as some other people, have shown that androgen exposure seems to be less reversible or not reversible compared to estrogen exposure. In adolescence, there is a muscle thickening, both in males and females, but more so in males. And then this is where we expect that tri-layered lamina propria to be fully developed. Now, as we said, there are gender differences in the vocal folds, as well as the thyroid cartilage itself. There's generally the size of the vocal cords, as well as the thyroid cartilage. The position of the vocal folds within the thyroid cartilage is different. Obviously, the males are slightly more in the middle because of the differential growth. And then there is a little bit of a histologic difference in the makeup of the vocal fold. It has been shown that there seems to be a little bit of a higher elastin content in the cover of the male and a little bit of a stiffer vocal ligament. And then the way that the elastin is laid down in males and females is slightly different. And this may lend to a slight difference in the rheologic properties. I wanted to remember to just talk about, the vocal folds are just the motor. They just go, but the rest of the vocal tract and its development is also very important. This shows that an infant or a child versus an adult, the larynx descends over time. The position of the tongue base makes a difference. The head size, as well as the development of the sinuses and the configuration of the sinuses, all lend toward vocal tract resonance. So this isn't just a vocal cord issue. I talk about the resonance because when you look at over time, an adult and then going into an older or a senior, there are lots of other changes in the vocal tract that don't have to do specifically with the histologic changes in the vocal cord itself. As you can see, the kyphosis, as well as the lowering of the larynx within the neck, can create resonance changes. And I would dare say that the two entities in the middle part of this slide are going to have the same resonance and voice as the ones that are on the lateral aspect of the slide, even if the vocal folds haven't changed a ton. So we did allude to age-related histologic changes. There has been many studies from the early 2000s on, and I think obviously they even did them before that, but looking at what are the just normal age-related changes in the vocal fold. These, I want to just stress, are not necessarily pathologic, but they may lend themselves to what we hear and what we consider presbyphonia. So Filho and his group in 2003 out of Brazil did some cadaveric studies, which showed, not surprisingly, that there's a decreased epithelial count as well as a decrease in the superficial lamina propria thickness in vocal folds. They did look male and female, but I think they didn't have as many females. So, but in general, they found this across the board. Then many papers, including Ono in Japan in 2009, showed that there was decreased hyaluronic acid in the extracellular matrix, as well as an increase in collagen type 1 and type 3 in the lamina propria. There's also a decrease in elastin, and there is a little bit of a gender difference where it seems that males have more atrophy of the muscle as well as the SLP versus females. Now, I put this histologic H&E slide up because the left side is what's considered a normal control adult vocal fold, where you see a distinct some fibroblasts and blood vessels, and not a ton of the elastin, which is going to be the pinkish color within the extracellular matrix or lamina propria. But then there are two examples of older vocal folds, which show really dense pink and thus collagen kind of laid throughout that. And that's going to obviously have different vibratory capacity. The other things that do seem to change with time and age is salivary gland function. So again, this isn't just the vocal fold itself, but there is very good evidence showing that the salivary glands themselves do atrophy. And then there's a differential production of the serous and mucinous components of the saliva. And this may be part of what dehydrates the area and causes some difference in the shear. So what are patient complaints? I, again, have a couple of voice samples here.
Count 1 to 10. Just count out loud.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great. And I think this voice specifically captures that breathy quality along with a strained quality. Those two things together are really hallmarks, not of presbyphonia only, but of any kind of glottic closure issue. So really presbyphonia, as we'll talk about, is a minimal glottic insufficiency. This is another one.
I'll count to 10 for me. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Great. Ooh.
Again, you can tell still a huskier sound. Some of the complaints are weakened voice, raspy voice. People say creaky or croaky. A lot of people say, I just feel like my voice has gotten froggy over time. A thin voice, voice that can't be heard. They keep getting asked to repeat. They're fatigued when they use their voice, and there's vocal instability.
Count 1 to 10. I would count to 10.
So obviously we do full history and physical on every patient, but what history might be more pertinent to figuring out whether or not somebody may need intervention for presbyphonia? The number one thing that maybe we don't always ask is, what are the voice-related activities that are important to this patient? As I mentioned, we've got people who are in their 70s who are still rock climbing now or doing other things, on Broadway. It's maybe not Broadway, but acting. And I have a patient who's in his very late 70s who's still a judge on a bench, and he can't be heard very well, for example. So what are those voice-related activities? Because that's going to determine whether or not they're happy with their voice. If they're hanging around, not having to talk and having people feed them grapes, maybe the voice isn't so important. Another thing that's important is pulmonary problems. If people have decreased pulmonary support, obviously they're not going to be able to generate the subglottic pressure in order to generate a good voice. Hearing loss. Now, there are so many papers, and this is something that has been ubiquitous from the 1990s when I'm looking at the literature. Really, anytime somebody comes in complaining of hoarseness, there is a feedback loop with hearing loss. There's a really great paper that's actually in press now showing that while there is a little bit of a bias because older people have hearing loss and have dysphonia and presbyphonia, hearing loss itself is an individual predictor of having issues with a loudness and stability in the voice. So if we identify a voice problem, but we don't also identify and correct the things that make it worse, we're not doing a good service for the patient. Neurologic disease. And again, this is in itself an entire topic, but as we age, the incidence of having, for example, a benign essential tremor, much less some sort of a movement disorder or a Parkinsonian type syndrome, or having cognitive issues, even if it's a past stroke, mini strokes, etc., some element of dementia, all of these things can come into play when it comes to good, adequate voice generation. I already alluded to kyphosis and scoliosis, and then I actually think of weight loss along with systemic disease because people often complain more of voice issues if they've lost weight quickly. The theory being that maybe the vocal cord muscle has atrophied even more quickly. And then medications, because we're always thinking about dryness and if there are some medications that may be causing some of this issue. Then when we look at the physical exam, just when you walk in the room, assessing the posture of the patient, the breathing, the respiratory rate, whether they're coughing or wheezing can make a huge difference. Assessing that neurologic status, of course, with our cranial nerve exam, but whether or not you notice a tremor, not just in the voice, but somewhere else. If you notice any dysarthria or hypophonia, because hypophonia is a totally separate issue, but they can make a huge difference as far as generation of that subglottic pressure for projection of the voice. I and most laryngologists will assess vocal quality, and we use many different scales, but one of the easiest is the Gravis scale, which gives the voice an overall grade, and then also looks specifically at roughness, breathiness, asthenia, and strain in the voice. So the last thing is, again, just dryness and pooling. So if you look in the oral cavity and there is just a desert, you know that the vocal folds also look like that. And I often will tell my patients that if the lips are dry, the vocal cords are dry. So what are our assessment tools as otolaryngologists as well as laryngologists? I actually am going to start at the bottom with this because the stroboscopy is the laryngologist's workhorse. This is a video stroboscopy. Say hum. Great, just breathing in and out through the nose. Say for me, cough, cough, cough. And say for me, I didn't want to do that. I'm trying to stop it so I can show you. For me, cough. Good. And again, just take in one breath and without pushing too hard, just say few seconds. Oh, it's not going to let me stop it. So again, the point of this is that I was trying to show you the vocal fold closure. When the vocal fold actually closes, even in males, these are moving at least 100 times per second. So we really do need the stroboscopy to show us how much the vocal fold is closed versus open. And typically when people have atrophied vocal folds, they're what we call open phase predominant, where we can see a little bit of closure, but in general, we can measure how open the glottis is based on the stroboscopy. And then the other thing that it shows that's very important is mucosal wave. Typically mucosal wave in an elderly person who's just having atrophy is going to be fairly normal. And I make this in contradistinction to other people who may have bowed vocal folds, but who have sulcus vocalis or other scarring conditions. And the mucosal wave will help us identify those pathologic conditions versus presbyphonia, which isn't necessarily a pathologic condition. Then as we move up this slide, most ENTs do have light endoscopy that they can look at the vocal folds. And again, you can see other pathologic things that may contribute to hoarseness, like tremor, vocal spasm, and paresis with this. There is subjective assessment, as I previously mentioned. There's the Gravis tool that any physician can use. And then there are patient self-assessment scores. The typical ones we use are the Voice Handicap Index or the Voice Handicap Index 10, which I think a lot of people are using now because it's very well validated and it's much shorter. There is actually an aging voice index that has been published recently. It is 23 questions, so I don't tend to use it as much, but it is a validated scoring system that patients can take pre and post intervention. And of course, as with most fields, we do have a voice-related quality of life scale. Especially if you work in academics, but some of this may be available in private practices like mine. Most of our speech and language pathologists will do the acoustic and aerodynamic measures of the voice for us. Aerodynamics, anyone can do something like a maximal phonation time, which is actually having the patient breathe in and say ah as long as they can. And there are some normative values for this. It's thought that the normal not elderly adult has a maximal phonation time somewhere between 24 and 30 seconds. Elderly, and I think they define that as over 65. This goes down quite substantially, so that the mean rates are between 14 to 18 seconds in elderly adults. And then I tend to use 10 seconds as sort of a borderline number. And then I typically will recommend some sort of intervention if they're less than 7 seconds. And then acoustic measures like jitter and shimmer, as well as noise to harmonic ratio, are measures that can help determine how pathologic a voice is, as well as help decide as we are doing intervention, whether or not we've been successful. Oh, let me go back. So what are some non-surgical treatment options? The left-hand side of this slide is sort of things that you can suggest even as the ENT. And then the right-hand side of the slide is what I consider the mainstay of non-surgical treatment for patients, which is speech therapy. So again, vocal hygiene, something we can even just have a sheet in our office and give to patients. This is really trying to address the little things that they can take care of on their own. For example, hydration and lubrication. As we already said, it's common that older people do have lubrication issues, especially. So giving tricks on how to improve that with steam, glycerin-based lozenges, anything else that may stimulate saliva production for them. Those are very small things that may help them get through a lecture, get through a court day, etc. Medication management, making sure they're not on any medications that they don't need or that may be more drying. For example, a lot of our patients in general, perhaps if they're on lots of antihistamines for allergy, those are going to be drying. Can they get off of those and do something that is more topical, or perhaps some medications that are less drying? And then compensatory techniques, like using a microphone if you're going to be on Zoom all day. Even though most people don't need to yell when they're on a computer, we seem to want to fill the space around us. I'm sure everybody has had this experience. Whereas I notice if I can have them put a microphone right in their ear or use a headset, they don't feel that they need to fill the room in the same way. And then little things about environmental surroundings, like if people are going to have meetings or even have social activities, going to a restaurant that doesn't play background music, for example, very small, basic things. And then medical management of exacerbating factors. Again, I think it's also Hearing Awareness Month. So hearing aids, hearing assessment, extremely important for the hoarse elderly patient. I have a patient who says every time his hearing aids are not in, his voice sounds wrong and he has something wrong. He puts his hearing aids in. Oh, there's his voice is back. So there's a feedback loop that we cannot ignore. Neurologic treatment. Again, if people are on or optimized on their Parkinson's medications, for example, they're going to be able to overcome some of the hypophonia and be able to use their voice better. Possible treatment for tremor, although that is a little bit of a difficult one. And then any kind of pulmonary management, pulmonary toilet. Now, I want to spend a minute on the speech therapy, not specifically going over the techniques, but really giving kudos to our partners in voice outcomes, because speech therapy is the mainstay for presbyphonia. Presbyphonia is not specifically a pathologic condition, and sometimes just using some of these techniques to rebalance the voice make a huge difference. So the goal of speech therapy, as I just said, is balancing the respiratory support as well as the laryngeal effort. So a lot of time people have gone through these slow changes and they've developed the secondary compensatory techniques that aren't actually helping them speak as well as they can. So voice therapists will undergo many different assessments and then use vocal function exercises, semi-occluded vocal tract, Lee Silverman voice training, more specifically for Parkinson's disease, etc. Phonation resistance training, which is meant to actually try to strengthen the muscles, as well as respiratory support techniques. This is a figure of some results from Kaneko et al., which was just published last year. And the paper is titled Physiologic Effects of Voice Therapy for Aged Vocal Fold Atrophy Revealed by EMG Study. This was in Journal of Voice. And I'm not going to really go through it in detail, but as you can see in the upper left, as well as the lower right, there are certain things that don't change no matter what you do with voice therapy. So the mean flow rate is just how much air is coming through, and the Bowing index is how thin the vocal folds look. Okay, voice therapy doesn't change how the vocal folds look, but as you see the maximal phonation time in the middle upper part of the screen, there is a significant improvement in maximal phonation time. The subglottic pressure increases. In the middle row, the jitter and shimmer decrease, which is a good sign. And then in the bottom left, the voice handicap goes down. And those are extremely important in making people functional and feel good about using their voice. So of course, I'm a surgeon, surgical treatment options. As we said, this is often and almost always considered a glottic closure issue. So surgical intervention is meant to close the glottis, close the glottis, close the glottis, and then maybe correct a height differential if there is a little bit of paresis or if the vocal folds are a little bit off. There are many different techniques for this, and the most utilized at this point are going to be some sort of an injection laryngoplasty or a medialization thyroplasty. And I also put just a little bit about gray mini thyrotomy in. I was doing these a lot more when I was in academics because you need a couple people to help you as you do it. But there's a couple different ways that we do this, and I'm going to just go through them quickly. Now, injection laryngoplasty, I think, especially for the laryngologist, is the workhorse because it's something we can do right in the office. Somebody comes in, they have a gap, you say, hey, let's try this. You put it in, they feel great, usually very quickly. And it's a proof of concept tool for us. So I put in autologous versus non-autologous. And I also included for non-autologous, these are the ones we do that are the gel foam, collagen, Restylane. Now there's Prolarin. I put Teflon on just for posterity because I don't think many people use it anymore. And I put test saline because one of the things I put in the slide for is to remind us that this is not a condition that's like vocal cord paralysis or paresis that might improve over the next 18 months or something. This is pretty long term. So I really do try in these patients to do one of two things. Either do an injection that's going to last very short, but that gives the proof of concept, or just inject them with something and then hope that they never come back because maybe they just feel like it's a little bit better. Maybe they're very old and can't go to an operating room. But the point is most of these injections, just like Botox or something, do need to be repeated. And then you're setting a patient up to have this more like a voice lift where they need to come back every 6 months or something like that. And as far as medicine's concerned, if you have something that's a little more permanent, I would think we would use it. So one of the more permanent injection techniques would be autologous fat. And I do tend to use that quite a bit for small gaps. And this is a Bruning syringe just because we don't see them as much as we probably need to. Now I'll go just to the techniques for injection laryngoplasty. The left two are the ones I use the most in the office. And this is the cricothyroid as well as the thyrohyoid approach. And then I used to do a lot more of the transoral that's on the top, but I don't have that equipment anymore, but a lot of people get trained in that way. And then the bottom right is our operating room direct laryngoscopy, which we all are trained on. So I want to go through a couple of techniques and then a couple of patients, and then hopefully we'll get to the questions or comments. So this is actually a test saline injection through a cricothyroid approach. And I'm just going to show you, you're going to see the little needle coming up underneath on the right side first. And with saline, especially, we really do over inject because it doesn't last very long. And then the other thing to remember about presbyphonia is this is typically a 2 vocal folds. Okay, you have to do both sides, not just one. So let's see if I can get this. Maybe I can't get this. Nope. This didn't happen before. Okay, so I'll just play this one if I can. So again, this is showing the left vocal fold breakdown, and the importance of this is that you just really can't see as well on the second side when you do it. Then I'm just going to show a thyrohyoid approach. And the thyroid approach, this is a steroid injection that I do in the same way, because I think you can see the bolus a little better. The other thing to remember about a lot of these, unlike a vocal cord paralysis, is you're not really pushing the vocal cord over that much. These are much more subtle changes in the vocal folds. You don't need a lot of injectate, but just to show you the technique, you're going to see the needle coming through the pinny. And then going into that left vocal fold. The steroid injection we do a little more superficial than we would the other, but you can see that this goes quite nicely. And especially in male vocal folds, this is a really nice way to inject. It helps anybody who has a very low larynx. That can be helpful. Lastly, because I know we're just kind of coming down to the time limit, permanent medialization. Permanent medialization, we typically will use like a Nishiki type 1 approach. And these were all really originally discussed in terms of a vocal cord paralysis. So you see even these figures are all unilateral. Presbyphonia is a bilateral disease. It doesn't just happen on one vocal fold. So we take this, you got to multiply it by 2 for every procedure. And you can use Goretex, you can use Silastic, hydroxylapatite. Those are, I think, the most common. And the middle photographs are just showing essentially a Silastic block versus Goretex ribbon where you lay it in. And then the right side is showing the idea of a mini thyrotomy, where, as you notice, the window through the thyroid cartilage for the Ishiki type is a little bit more orthogonal to the vocal fold. Whereas with the Gray's mini thyrotomy, you're actually making a tunnel that is parallel with the edge of the vocal fold and usually a little bit closer toward the vocal ligament. The idea was maybe even putting stuff within the lamina propria. I have never been successful at getting fat to stay in there, but I have done rolled alloderm or fascia in that area. So that can be helpful. And I just want to show a couple of examples. This is a Goretex thyroplasty on a gentleman. This is his voice.
Just count to 10 for me.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, got that very classic breathy.
For me, cough, cough, cough.
Cough, cough, cough.
We saw this one before,
And
so
again,
I'll
just
show you.
taking
Again,
that breath
he's
and
very
without pushing too hard. Just say few seconds. Good. And then a little higher.
This gentleman loved to sing. He couldn't sing anymore. We did a bilateral Goretex thyroplasty. Here's his voice outcome.
First, just count to 10.
1, 2, 3, 4,
He's also had
5,
some voice
6,
therapy, so you can
7,
hear some of
8,
those
9,
techniques.
10.
Great. Ooh. Ooh.
Using that falsetto now. And this is to
For me,
vocal
cough,
cord
cough,
closure.
cough.
Cough, cough, cough.
Good. Breathe in through the nose. And good. Breathe.
So again, I think if I had to go back, I'd put a little more on that right side, but it is what it is, and he's happy. And then the last one, this is another gentleman, voice sample. Count 1 to 10. Just count out loud.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And again, we heard him before, but the other thing about him that is very interesting is he has a little bit of compensatory falsetto. So when we're talking about male voices maybe getting a little bit higher as they age, I'm wondering if some of that isn't a little compensatory falsetto. Here's his vocal folds. Good, breathe in. And he. So good, breathe in. Not bad. He's closing. But then post bilateral Goretex thyroplasty, listen to his voice. First, just count to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Great. That's his real voice. He's using this high-pitched voice to close and have power because he's working still in his late 60s and he needs to have power in his voice. And again, this is his video. Good, breathe in. And then take one look at me. Just chin a little farther forward. Excellent. Take one swallow. And then say for me. He. I just want to get it back down into lower voice, which just give me 1 second. There we go. And he, a little lower. Much better closure. He's still squeezing a little bit and he is doing some voice therapy, but it's really amazing. He was waiting to have this procedure so we could go interview for new jobs because the voice was so difficult for him. Say for him. First, come on, go forward. There we go. So I just want to spend 1 minute because that's about what we got on emerging technology. So everything that we just saw is just trying to outdo the effects of time, improve the glottic closure, plump the vocal fold, and nothing is really restorative. This is more regenerative medicine techniques that are emerging at this time. And they, at least when they're being presented at some of the meetings, sound fascinating, and I'm really hopeful for our future. The one that's been studied the most is the one on the bottom, which is the beta FGF, or the fibroblast growth factor injections. This is both for vocal atrophy as well as scar, and they have been able to pretty consistently show an increase in in hyaluronic acid in the vocal fold matrix, as well as a decrease in the collagen type 1 level. And then the figure that I put up here is just a new paper by a different group, but sort of going along with the beta FGF injections. They use this thyrohyoid approach in the office. I believe they give 3 sequential injections, and then they do acoustic, aerodynamic, and stroboscopic measurements before and after. So I'm really hopeful for this. And then a newer one that has come out is hepatocyte growth factor injections. They're finding that these have some anti-fibrotic activity. And of course, that's what we're trying to get rid of, the collagen and the fibrin that's laid down. Mesenchymal stem cells. You know, it's so funny. I used to be very suspicious of all of the orthopods who were doing the PRP injections and stuff until we started doing them in the vocal folds. And the idea is they probably do have some of these stem cells that allow for some regeneration. And then there's a lot of vocal fold scaffolding work being done where they take out the cells, but they leave some of the growth factors. So this is just really exciting stuff. And I'm hopeful because we don't have anything great for scar, and what we do have for atrophy doesn't really reverse time. It just tries to compensate for it. So in summary, vocal fold does change throughout life, and that there is this increase in collagen, decreased elastin and hyaluronic acid over time, decreased fibroblastic action, and all of these are normal factors in presbyphonia. Glottic closure is the most important thing, and voice therapy can help balance the power source, the source of the vocal fold, of the vocal fold vibration, as well as the filter or the resonance system. And then addressing glottic closure with surgical means can improve the voice handicap and the voice-related quality of life, which are both the most important thing to the patients. And I'm just putting a picture of the sound stage for the voice where they were taping since I was in LA recently. So I want to thank everybody. This is my 90-year-old dad who hopefully these techniques and my knowledge have helped him be able to keep his voice for years. So I can take any questions. I don't know if there's anything in the chat. Let me know.
I think there's a couple of, I'm sorry to interrupt.
No, not at all. I just was turning on the chat here.
I think Dr. Myers had two questions about the history and then another one about COVID long haulers.
Sure. So caffeine completely drying, tobacco, vaping, marijuana, pollution, all of these things not only come in terms of presbyphonia and vocal quality, but in general with vocal quality. So we definitely ask about them. The polluted working environments are the hardest for us because we have no way to measure that. But again, along with our vocal hygiene, I've had people writing letters to have humidifiers on their desk, before all this, wearing masks at work when they were actually mandated not to wear a mask, even though it helped them. So for sure. Now, because I'm in private practice, I don't see a ton of COVID long haulers in the way that an academic physician may, but there are so many different problems that are kind of becoming elucidated with COVID long haulers, as far as neurogenic issues, as well as intubation defects, things like this. So I don't know if we can group it, and I certainly don't think we can group it by age, because what I'm seeing is the stenosis patients and everything, they're very young, actually. So that's my one comment on that. If there are some people who are in academics, they may have a bit of a different exposure to that.
Are you seeing, just to change the topic a little bit, are you seeing a lot of stenosis related to sort of prone intubations and what's happened for the COVID patients?
So, not as many now as we did over last year. I mean, I think 6 to 9 months ago, it was crazy. Like it just seemed like people would walk in, they said they were hospitalized for COVID and they were going, and I was like, so it was tough. And I definitely have some that were trached, seem to be okay. They have a scar tissue on the vocal folds. They have that posterior glottic gap. And again, I'm sort of just trying to get them to be happy to be here and try to get as much voice as possible. But those are, as we know, posterior glottic issues are, that's hard for everybody. And unfortunately, our management, along with the inflammation from this disease, has given us another group of those patients.
Okay. All right. Are there any other questions in the chat? No, wait, there's a Q&A. It is from Dylan Beans. He is a medical student at UT Southwestern who is, I believe, also a singer. And he's interested in going into laryngology, and I think very interested in laryngology. So his question says, in patients who have undergone injection-laryngoplasty with saline, do you ever receive comments related to voice cracks or breaks in vocal range because of the overfilling that is done due to prolonged effects of the procedure?
So that's one of the reasons I like saline, is because it doesn't last. That saline, if you look at that same patient, even a few hours later, it doesn't look like that. So saline, no. Restylane, yes. So that's one of the problems with these is, most of our training is done in people who have vocal cord paralysis. Vocal cord paralysis, you have a flaccid vocal fold, and you just go in and you try to inject that so that the other side can touch it. Now we're using those same techniques in people who have bilateral mobile vocal folds, and you don't know what their volume deficit is. So you're kind of looking, and while the patient is sitting there breathing, trying not to gag, you're going, I think that looks like enough. And I get a little bit of heaviness on one side versus the other, things like that all the time. And it can contribute to a little bit of roughness in the voice. I always bill these as better for projection and increasing subglottic pressure than I do a smoothing the voice. The voice can still be a little bit raspy, but again, the injection never lasts forever. And some of the voice therapy techniques are able to compensate a little bit for that. But especially in singers, when we're doing these, I am not hesitant, but I lay it out there as far as what this can and can't do.
All right. Okay, everyone. Well, don't forget to register for the CMZ with Henry Ford. If you have registered, I've left the message in the chat. Text 50326 to 1-833-999-1484. And that will conclude the session. I'll stay on for a few minutes as people log off. But thank you so much, Dr. Ivey. It was really great for
Thank
you
you,
to give your
Romaine. It's
talk. It was
always
good
nice to
seeing
be
you again. I
back.
know I haven't. Hopefully I'll get to see you in person
I
soon.
know, in person in Atlanta.
I will be in Dallas, everyone. So if you're coming to COSM, come hang out and, feel free to email me. And if you have any ideas, I'm now the editor-in-chief of the Laryngoscope Investigative Laryngology. If you have an interesting article you want to do open access, send it to me. If you have interesting ideas for review articles, send them my way. And I have a lot more leeway now.
Good to know.
All right.